Good morning. Today we do near drowning. Near drowning is defined as any time a person that has been submerged in water long enough to require cardiopulmonary resuscitation efforts. Deaths due to drowning are caused by asphyxiation. Deaths due to drowning are defined as any death that occurs within 24 hours of submersion. So near drowning is any time a person has been submerged in water long enough to require cardiopulmonary resuscitation efforts. And drowning is defined as any death that occurs within 24 hours after submersion. Our objectives for today are to define near drowning in your own words, compare wet and dry drownings, organize the sequence of events, using a case study, formulate a plan of management and treatment for a near drowning patient in saltwater and freshwater. Using a case study, determine the predicted outcome for near drowning patients. Some terms I want you to look up, and I'll give you some time here, but I want you to know what asphyxia is, dry drowning, wet drowning, the diving reflex, and secondary drowning. So I'll give you time to look those up, and when you're ready, you can come back to the presentation. So 8,000 plus drowning incidents occur per year in the United States alone. The peak occurrence, which probably won't surprise you, is 4 years and younger, in that toddler age range. Bathtubs and residential swimming pools are the most common incidents of drowning, and usually due to a lack of supervision. And usually it's less than 5 minutes, which was kind of shocking to me, but lack of supervision for less than 5 minutes. The second peak occurrence usually occurs in adolescent boys in natural bodies of water. So case number one, we're going to take a look at 2 case studies. This is the first one. A little background information. The mother was preparing a bath for the child and went to answer the phone. Upon returning, the mom found the child in the water, head submerged, flailing about. Upon arrival at the emergency department, they found the child to be severely hypoxic and acidotic. So think about that for a minute. What do you think was happening here? So they decided to intubate and mechanically ventilate the patient. A bronchoscopy revealed absence of excessive fluid in the lungs. So think about when you looked up your terms, which one of those terms identified the excessive fluid in the lungs, or absence of excessive fluid in the lungs. There is also some airway inflammation and edema absent. So the bronchoscopy basically revealed nothing. It was almost normal. So think about that, and what kind of drowning do you think that was? The following day, the child was extubated and discharged from the hospital within 2 days. So when you look at your terms that I had you look up earlier, do you think this was a wet drowning or a dry drowning, and why? What assessments did you perform and why? So you can write those down. And then what were the findings? So predict what you found on your patient. And then what treatments were initiated. And you can just kind of brainstorm here. Think about what treatments we do for this child. And we'll discuss those in class. So to continue on, water entered the voice box or the trachea, and it stimulated a laryngeal spasm. So that should have given you a clue that this was a dry drowning, because only a small amount of water or aspirate was needed to trigger a laryngeal spasm. And according to our earlier results, the bronchoscopy found minimal water and no edema and no inflammation present. When a person aspirates some water or anything, it can trigger a laryngeal spasm, and it usually lasts 30 to 60 seconds. The laryngeal spasm occludes the airway, but the person's fight or flight response is will respond into that effect. This means their heart rate increases, their respiratory rate increases, blood vessels vasoconstrict, and the blood pressure rises. So what happened was the respiratory effort increased despite the lack of airflow. The metabolism increased despite the lack of oxygen. So what happened here was, as the increase in heart rate and respiratory rate continued, the body still wasn't getting any air or oxygen into the bloodstream and couldn't get any CO2 out of the blood. So remember, I told you at the beginning this patient was extremely acidotic. So this is what happened. The metabolism and oxygen consumption was so increased due to the body's struggle that it caused hypoxia and acidosis. So they went into a respiratory acidosis with hypoxia. This scenario is termed a near drowning, more specifically a dry near drowning. The patient survived past the 24 hours of being submerged in the liquid. And remember from our very first slide, that's what defines a near drowning. The bronchoscopy revealed absence of water in the lungs, so the cause of the near drowning was actually the laryngospasm. This is what defines dry drowning. So this case was a case of dry drowning due to the laryngospasm. Okay, so this is case number 2. This involved a 14-year-old boy fishing in early spring. He fell out of his boat and did not return to the surface. The family looked for him. They were unsure how long he had been gone. They called the emergency medical service, and they finally pulled him to shore. So they got EMS there. CPR was initiated. They intubated, ventilated, and transported to the emergency department. Upon finding him in the emergency department, you found that they were already starting to rewarm the patient. And then when they did the bronch, or when they intubated him, they found thin brown fluid section from the ET tube. Okay, so they started mechanical ventilation. SpO2 was 98% on 100% with a PEEP of 5. Another little background, the EMS found the patient apneic, bradycardic with a low temp, about 33 degrees. Extremities were cyanotic, and then they continued on to intubate. So some questions I want to ask you and see if you can solve these. Why was the patient bradycardic? Why was he apneic, and why was his temp so low? So think about what you know about lakes in early spring in Nebraska, and also think about what was the cause of the bradycardia. So when you looked up your terms earlier, you were looking up diving reflex, which is found in all known mammals, but less so in humans, but it does happen. This reflex puts the body into oxygen saving mode to maximize the time that can be spent underwater, and it includes 3 factors. So one of them was the bradycardia. The second one was the peripheral vasoconstriction, which would cause the cyanotic limbs, because it was moving the blood to the vital organs to keep them perfused. And then there was also a blood shift, the shifting of the blood plasma to the thoracic cavity, so the area between the diaphragm and the neck, to help avoid the collapse of the lungs under the higher pressure during deeper dives. In humans, when breathing with your face submerged, this causes a diving reflex, which increases proportionally to decreasing water temperature. So that goes back to our initial bradycardia and cyanotic extremities. Blood is removed from the limbs and all organs but the heart and the brain, creating a heart-brain circuit and allowing the mammal to conserve oxygen. So why do you think the brown fluid was that was sectioned from the ET tube? So think about that. Think about aspiration. So would you think this is a wet drowning or a dry drowning? You should have said a wet drowning because you did find thin brown fluid when you intubated the patient or when you suctioned the patient. And also I want you to think about with the lakes in Nebraska, was it salt water or fresh water? And then if you're from a different part of the country, if you're an online student, think about what kind of lakes you have in your area. With the freshwater drowning, a hypotonic fluid has entered the patient's lungs and it will be readily absorbed into the pulmonary circulation. So the blood volume will increase and put more work on the heart, leading to a sort of a pulmonary edema or a CHF type situation. And then when we warm that patient using the warm saline, we also are increasing the body temp, which can increase the size of the vessels, which will put more fluid into an already overloaded system. So think about that when you are in the ER. Do you really want to rewarm that patient, or do you want to let them be cool so it provides the necessary vasoconstriction to keep the body alive and to decrease the metabolism, and also to limit the amount of volume that's being put into the patient's system. So we still end up with an ARDS type situation from that pulmonary edema, from the aspirating the hypertonic fluid. It can wash away the lung surfactant, which will decrease compliance, cause alveolar instability, atelectasis, pulmonary edema, and increased pulmonary shunting, all which lead to hypoxia. If severe enough and the tissues don't get the oxygen they need, then lactic acidosis can occur. So when you were looking at this patient, what did you assess and why? What were your findings? And then what is the treatment for this patient? So answer those questions and we'll talk about them in class. So now we're 24 hours later. We look at the chest x-ray. It reveals engorged pulmonary vasculature and fluffy opacities. Breath sounds or crackles throughout. We're still getting small amounts of thin, frothy brown sputum. Heart rate is elevated, respiratory rate's elevated, blood pressure is a little bit on the high side, especially for a 14-year-old, and now our temp is up to 103.6. The patient is alert and agitated, still mechanically ventilated. SpO2 is 90% on 90%, FiO2 and PEEP of 10. So the physician and the therapist and the nurse determined that sedation will probably be the best course of action for this patient, which brings his vitals to the next set there. Heart rate 102, respiratory rate 18, blood pressure fairly normal, but temp is still elevated. So you recommend to get a sputum culture, and it shows the growth of Burkholderia pulmonale, which is common in lakes and roadside sand pits. Okay, so we have a compromised pulmonary system due to the fluid entering the lung, and we also have an invading organism. So think about what things you're going to do for this patient. And what happened in case number 2 that didn't happen in case number 1? What were the major differences between the wet and dry drownings? And also think about, why did the patient in case number 1 survive, and maybe the patient in case number 2 potentially did not survive or had a longer course of stay. So here's the sequence of events that can happen in some near drowning or ultimately drowning episodes. You have that initial panic, and then you can have some calmness or apnea, and then you remember that you need to breathe, so you try to get gulps of water to try to breathe. Then you may vomit, you may aspirate, go into convulsions from lack of oxygen, coma, and then death. Freshwater drownings versus saltwater drownings, that's something we need to look at. Typically in Nebraska, obviously we're going to have freshwater drownings, and then we need to look at cold and warm water, because there will be a significant difference from there as well. So as I talked about before, aspiration of hypotonic, which would be the freshwater fluids or waters, will cause some hypervolemia, can lead to CHF and pulmonary edema. when you aspirate that fresh water, you're going to wash away any of the surfactant in your alveoli, which will increase your surface tension and decrease your compliance, and will cause a high distension pressure, if you remember back to first quarter. Okay, it takes a lot of pressure to open those alveoli, which can lead to atelectasis, pulmonary edema, intrapulmonary shunting, hypoxia, and ultimately lactic acidosis. Salt water, on the other hand, will have the same end result, but now just from a different means. Now you aspirate hypertonic fluid. We're on the saltwater column now. Aspirate hypertonic fluid, which increases the sodium inside the lungs, which pulls fluid out of the pulmonary vasculature and into the vessels because of that osmotic shift, which then can lead to pulmonary edema, lack of compliance or lack of surfactant, unstable alveoli, atelectasis, and then the intrapulmonary shunting, hypoxia, and ultimately lactic acidosis. And ARDS fits all into both of these as well. So that's the difference between fresh water and salt water. So I want you to think of 5 or 6 things that can help predict whether there will be a good or bad outcome with the near drowning patients. So think about all of the things that went wrong in case 1 versus case 2 and what the major differences were. So I'm going to let you think here for a minute, and then we'll try to answer some of these. So age will be a factor, how long they were submersed, what the water temperature was, and what the water quality was. So think about those things. You may come up with more things, but think about those and we'll talk about them in class. So which anatomical alterations are present in a near drowning? So think about your 9 or 10 alterations and come to class with those filled out, and we'll talk about those. And then in summary, we talked about a dry versus wet drowning, how there was a laryngospasm in the dry drowning and aspiration in the wet drowning. Near drowning definition, remember near drowning is anytime a person has been submerged in water long enough to require cardiopulmonary resuscitation efforts. Drowning is defined as any death that occurs within 24 hours after submersion. And then think about the sequence of events, and then also the saltwater versus freshwater effects.